Good morning, everyone. Welcome to TeleShadowing. We are live streaming this session to YouTube. We'll have a Q&A session at the end, and you can ask questions in the chat box and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Mirza. Dr. Mirza is an associate professor of pathology and medical education at Loyola University of Chicago, Stritch School of Medicine. He completed his medical education at Aga Mirza University Medical College, followed by his PhD training at UIC in pathology residency, Hematopathologist Fellowship and Medical Education Fellowship at the University of Chicago. He serves as the Vice Chair of Education, Hematophathology Fellowship Director, and Program Director for the MS in Medical Laboratory Science. Now I'd like to request Dr. Mirza to begin today's session. Thank you.
Thank you very much for having me. Can you see the screen?
Yes.
Excellent. All right. Well, it's a pleasure and an honor to be here today. As was kindly introduced, my name is Mirza, and I am a pathologist. And today what I would like to do is use this time to introduce you guys to this idea of pathology and laboratory medicine, what it entails for anyone who is a kind of a biology major, pre-med, or in medical school. It's a passion of mine to kind of make sure that everybody understands what the pathology lab is and what laboratory medicine is. And so today I was asked to also share my journey to pathology, and so I will kind of weave in some personal stuff as well as talk about diagnosis. All right, so let's get the boring stuff out of the way. I was born in Pakistan, and my parents were both physicians, and we moved to the United Kingdom when they were basically post-graduating. And so I grew up pretty much in England in a small town called West Bromwich, and it's near Birmingham. We moved back to Pakistan for my higher secondary education, and then I went to Aga Khan University in Karachi, where I completed medical school. And then after that, I had kind of a circuitous route, but I wanted to see if research is something that I'd like to pursue in life. And so while I didn't do the MD PhD programs that are available in the US, I actually broke the MD and the PhD separately. So then I came to Chicago, and at UIC, I completed my PhD training. And then I went to pathology residency, which is in anatomic and clinical pathology. And we'll speak a little bit about what the routes in pathology education are. And then I specialized in leukemia and lymphoma. So that is what I diagnose right now. That's hematoppathology. And as Manahil mentioned, I also did a fellowship in medical education. And what I've tried to do is really create a career path which really takes into account medical education, because that's a very big part of who I am. This is my first faculty job. I finished training 6 years ago, and so I am now Vice Chair of Education and an Associate Professor at Loyola University Health System, which is just outside, it's in the Chicagoland area, just outside Chicago city limits, for anyone who's familiar. I thought it would be fun to show you some pictures. If anyone is familiar with Pakistan, I went to Aitchison College, so that's me on the top left. Dramatically talking to people. And then on the right is the Aga Khan University campus in Karachi. If you haven't seen it, it's a beautiful campus, wonderful school, very privileged to be an alumnus from there. So today I will be touching upon pathology as a career, kind of my journey to pathology. I will be sharing with you some basic outlines and constructs of how to think about leukemia and lymphoma. I'm going to try and keep it basic, but I know that there are definitely some medical students in the audience as well. And I want to kind of be able to share my passion for hematopoietic cells. So I'll kind of show you some pictures and talk about bone marrow and lymph nodes, etc. I am also very passionate about social media. I've spoken at several platforms about this and how you can use it to build your brand. And while today's teleshadowing, I don't have enough time to talk about it, I will kind of give you 2 tips or tricks in the end to kind of think about how you can use that as part of your professional presence. So these slides are actually from one of the UK pathology organizations, the data is from one of the UK pathology organizations. And I thought we'd start with some myths. And, towards the end, when we do the Q&A, I would love to kind of hear your experiences with pathology, if you have any, right? What do you think a pathologist is? Or are you familiar with pathology being a branch of medicine, or do you think that it's more of a technical work that non-physicians do? And I think that when you consider pathology overall, you'll find that most people think about pathology, and this is a myth, it's all about dead bodies. You know, the jokes and the memes are always like, oh, the patient is already dead. What's the point of like giving a quick diagnosis because the patient is waiting? You know, I mean, and I guess they can be funny, but they're, pretty wrong. The pathology is way more than just autopsies. And in a focus group that the UK group did, they asked the general public about what they think pathology is. And I don't know if you watched the X-Files or not, but maybe I'm dating myself, but that's Gillian Anderson playing Scully. She was a forensic pathologist in it, and like CSI and like all of these kind of crime scene investigation shows is basically how one thinks about pathology. And this is some of the focus group comments that they said. It's the morbid side. People become a doctor when they don't want to, a pathologist when they don't want to deal with people, so they'll deal with dead people, and you're left in the morgue with dead bodies. And this couldn't be further from the truth. In the same poll, when asked what a pathologist does, and the answers were death, diagnosis, blood, whatever, like pretty much 60% of all respondents said that they deal with things about death. And the reality is, the pathology fact actually is that forensic pathology, which is an amazing branch of pathology, which does deal with post-mortem examination, really is just a very small fraction of what a pathologist or a laboratory medicine specialist would do. But the reason why people typically think about it as the main thing is because of how it's portrayed in the media. The idea that, pretty much, you're a detective, and like, when is that detective work really happening? When the patient has died. And so this does it, I think forensic pathology is one of the coolest subspecialties. I wish I had done it, and it's not to take away from forensic pathology, but it is just one part of what we do. And so I think it takes away from the breadth of the experience. So the myth then is that pathology is just one specialty. And while it is under the banner of one name or one specialty, it is actually a lot of specialties. So here I'm going to list a few of them, and I'll try and describe what they are so that if you guys have any questions, you can put them in the chat. So let's start with surgical pathology. So surgical pathology is the pathology or the observation or analysis of the specimens that come from surgery, right? So whenever there's a surgeon who is performing a procedure, she or he will be sending material to a laboratory. And when that happens, in the laboratory, what we have to do is we have to dissect it, open it up, and see if it's cancer or not. This could be a very small biopsy. It could be a very large resection, for example. It could be an entire liver, or it could be part of the stomach. So who is the individual who actually makes the diagnosis on that tissue? It's a pathologist. And anything that comes from the surgical suite pretty much and is looked at under the microscope is known as surgical pathology. Now, surgical pathology actually has many subspecialties within it, right? So you could effectively become a specialist in any part of surgical pathology. So for example, if you wanted to become a skin specialist, looking at skin samples, you would become a dermatopathologist. If you wanted to become an OB-GYN specialist, meaning looking at the female genital tract and specimens from the uterus or breast, etc., then you could become a gyne or breast pathologist. Similarly, I am a specialist that looks at leukemia and lymphoma specimens, so I am a hematopathologist, right? Similarly, brain pathology, neuropathology, etc. They're more than just surgical pathology, though. There are other branches of pathology, which includes things like blood transfusions. Transfusion medicine is one of them. And hematology, the laboratory where all the blood specimens go, right? So all of the specimens that when you go to clinic, you've probably been doing it since you were a child, you've been giving blood samples. Have you ever thought about where those samples go? How are they reported? Who looks at them? Is there a physician behind the scenes? And I think that's basically one of these misconceptions that one assumes that the physician that you're seeing in person is the person that is actually giving you that diagnosis. And while they're definitely relaying the results to you, there's another physician behind the scenes that is actually talking to them. And so that's basically what a pathologist is. Another part of pathology is medical microbiology, or basically studying bugs and what types of infectious diseases there can be. So the infectious diseases effectively would be anyone who has an infection in the blood or an infection, let's say in a wound, where does that material go to be tested, right? Who tells you which bug it is? And it's effectively a pathologist or a microbiologist, a medical microbiologist, who can kind of put that together. There are other parts of it too. There's clinical chemistry, and I'm going to quickly show you some slides about clinical chemistry and kind of review with you, kind of try and put it together as to whatever your experiences were. You have in one way or the other interacted with the pathology laboratory indirectly. You just were not aware of it, right? Moving on to genetics, if you go down to the genetic level, right? So right now, if you are thinking about hereditary, predisposition to diseases, if you think about things such as Down syndrome, if you think about things such as cancer with genetic mutations, who are the physicians or the, doctorate level individuals who are effectively giving you those answers from genetics? And they are either PhD level laboratory directors or physician medical directors of molecular pathology laboratories. If we think about personalized medicine, this idea that now no two tumors are the same, and you can actually give medicines that are targeted towards one particular therapy or one particular tumor based on what type of genetics it might have, that is also coming from a pathology laboratory. And, I've also put histocompatibility and immunogenetics, and effectively, whenever someone is getting a transplant, then who is figuring out whether the transplant organ is going to be compatible or not, right? So who's working up the patient's immune system effectively to see what is compatible or not, and it's all pathology. So then in that way, the myth becomes that pathologists don't take care of patients. And I understand why people think this. They think of this because we don't necessarily see patients directly. And so how could we take care of them? But I would argue that we're actually taking we play a very important role in their care, right? Without pathology, there's no medicine. So, I think that the patient-facing colleagues would be really blind in trying to analyze things or guess things. I mean, of course, you'd have radiology, so you could see the imaging, but you wouldn't have any tissue diagnosis of anything. And so that would be kind of a problem. And the focus group in this particular in this particular area said that, it's more of a science. They don't want to deal with people. You never actually see the pathologist. It would be nice if pathologists were involved in patient care, but I've never seen one. And I think what they mean is that they aren't involved in seeing patients directly. But the reality is that some pathologists do work with patients in the clinics or on the floors. And these are patients, for example, blood bank and transfusion medicine specialists could be seeing patients directly when they're working up transfusion reactions, etc. Cytopathologists are a very specific type of pathologist that can be doing biopsies at the bedside, kind of putting a needle in a lesion and seeing what types of cells come out. And so there are ways that pathologists can directly interact with patients. However, I agree that most pathologists will not be meeting patients as part of their professional career, but that does not mean that they're not participating in patient care, right? Effectively, I think that they're really at the heart of patient care. So here I'm showing you a pathologist palpating a thyroid to do an FNA or a fine needle aspiration procedure. So this is one way a cytopathologist would perhaps be involved in direct patient care, meeting the patient. Naturally, I already mentioned the blood transfusion, so that's also one of the ways pathologists can interact with patients directly. So another myth is that pathologists work alone in labs doing tedious, repetitive jobs. I mean, in a way, medicine is all kind of tedious and repetitive, whether you're in a clinic, right, or not. But I think that what people don't realize is that in pathology, there is actually every, and this is a funny picture of like how people assume pathologists are working. And this is obviously furthest from the truth. There's no such thing as this blue specimen. I don't even know what it is. So the focus group said, well, it must be such a boring job. All you're doing is testing stuff and they're putting things in a machine and reading the results and you do the same thing all day. But, it's not true. We are members of a multidisciplinary team. We sit together with multiple other physicians and work together to take care of patients. And I think that, the future already it's here that collaborative multidisciplinary teams with the patient at the center are basically how we work. And we rarely work in isolation. There are perhaps some practices that are pretty remote and they'll probably be working in isolation. But the reality is that every day, for example, as a hematopathologist, I'm speaking to the oncologist or the hematologist and talking about patients and being involved, directly with them in the patient care. And it's actually a mystery every day. Like when I put the slide down on the microscope, I don't consider it being repetitive at all, because I think of it as every single slide is telling me a different story, right? And so that story is basically what the pathology is telling me, and I don't find it repetitive or boring. So here is Dr. Susie Lishman on the left. She is one of the prior presidents of the Royal College of Pathologists in England. And she is obviously working with either a radiologist or a breast oncologist, and they're looking at a mammogram together. And so she might read the pathology later on. But, pathologists have to be pretty aware of what types of radiological findings are present before biopsies are given. And it's just an image to show you that we are definitely part of an interdisciplinary team. And even in the laboratory, even if, medical laboratory scientists or biomedical scientists are putting together things in machines, etc., it's not necessarily repetitive jobs or the fact that we're working in isolation. I think this myth is like probably the worst one, that we don't diagnose cancer. I would argue to say that we are the only people who diagnose cancer. Almost all cancers, I would say, are diagnosed by pathologists, and they're based on tissue diagnosis. So the tissue is given to us, and once the tissue comes to us, we effectively look at it under a microscope, and it can be either blood or urine or other fluids, or a biopsy. And so pathologists really are making all sorts of diagnoses. And we tell other doctors what type of cancer patients have and how far it's spread, so they know what treatment to offer. And I think that, our stakeholder is really the other physician. And so many times pathologists are known as the doctor's doctor. So that basically the idea being that we are providing the information to other doctors so that they can take better care of patients. Now, this is a horrible myth that medical students don't need to learn pathology. That is not true. Pathology is at the heart of every single thing that they're going to learn. I know that at least in the United States, pathology education is mostly geared towards taking the step 1 exam. And I understand that with timing, like that's kind of how, what's important at that particular part of your career. However, I would like to say that you need to focus on pathology, because if you don't understand the pathophysiological mechanisms of disease, you won't be, I won't put it in a negative way. Let's put it in a positive way. If you do understand the pathophysiology of disease and the pathology of diseases, whatever type of physician you want to become, you will become a better physician for it. I can promise you, right? So understanding what the disease entities are at baseline really gives you power to understand what's happening to the patient, why they're presenting the way they're presenting, and what could be going on. In fact, I would say pathology is truly the heart of all of these subspecialties, right? I mean, in pediatrics, let's say if a patient has a fever and their white blood cell count is high, how do you know that the white blood cell count is high? Because they do a blood test, right? And where does that go? It goes to the pathology lab. In general practice, whether it be, looking at an individual's, let's say, lipid levels, or figuring out if they have any kidney disease, where is all of that information coming from? In emergency medicine, let's say that a patient comes in obtunded into the ER and they were found lying on the floor, right? And you don't know what's happening. Of course you have to do radiology, but you have to also figure out, did they ingest a poison? Did they ingest a drug? Did they have a heart attack? And so there are ways that we can measure markers in the blood to figure out, what's happening and help our emergency medicine colleagues take direct care of the patient. So I would say pathology really, and the pathophysiological understanding of disease, is at the heart of all of these things. Because I was sharing with you some UK data, I'm going to finish the UK data by saying that, there's a lot of tests that are done, okay, in the UK, although that's a completely different system. It's the NHS. Look at how many tests are being done. And in the US, here, this is some data from Loyola. And this is, where I work right now. And it's like, 4 years. But you can see that the number of tests that happen per patient in an inpatient patient is basically like around 50 to 60 tests that are happening for every person who is admitted in the hospital, all right? And those are all tests that are coming from the clinical laboratory. So what am I trying to tell you? Well, what I'm trying to tell you really is that every single person walking on the street is a pathology specimen. If you think about it, there could be someone who, let me say, so maybe this lady that's a beta HCG, so she might be pregnant. And so how will she find out? Well, she'll find out with a beta HCG level, and that's a pathology value, right? Somebody might be getting a blood test to look for, whether the kidneys are off or not. And then, or they might be doing a urine test to see what's happening in the urine, right? This patient may have this particular type of tumor. This patient may have been looking for a PSA, which is a prostate specific antigen, but it's less than 10. So perhaps perhaps they don't have prostate cancer. This patient may have radiological imaging of a lung mass, and they need to now look at, what tissue is actually in there. This patient had a blood smear, looks like the white blood cells are increased. And this one is having like a large genetic test done to see if there are any genetic mutations, et cetera, et cetera, et cetera. So really, if you look at a crowd of individuals, if you look at every single one of us that is in the audience right now, we have had tests done that direct our care, and that care is basically underlying any healthcare system. So that's why I like to say that pathology and laboratory medicine are the specialties that no healthcare system can live without. So there is data that 70% of all medical decisions are actually based on laboratory results. This is from a Quest Diagnostics brochure. And that seems like a really high number, but the reality is if you look at a patient's electronic medical record, I wouldn't be surprised if that's how many actually are there. But in many ways, we remain a black box. And for individuals like you listening right now, and others who might listen later, I can say that, my job I would like to do is to open up this black box so that you can see what pathology and laboratory medicine truly are, and why people would do them. So I would say that not only is it that we're looking at that a patient's organs and cells, but I think one of the coolest factors about pathology right now is the fact that we're also looking at their DNA, we're looking at their chromosomes, we're looking at all sorts of like very highly detailed levels of analysis to give a proper diagnosis. So here we'll pause for a second and then switch gears to look at what career opportunities might be present for a person in pathology. I'll use this time to also tell you how I came to pathology. And if there are any medical students in the audience or people going to medical school, I can tell you that your exposure to pathology in medical school will not be very great unless you seek it out, okay? I did not have much exposure to pathology other than studying for it in my preclinical years. I thought it was very interesting, but what happens is that you see a pathologist in medical school as a teacher, you don't see them working as a physician. So in order for you to see them working as a physician, you actually have to go to the pathology lab. And since it's not in the US, it's not a mandatory clerkship, so then you have to kind of seek it out as an elective, okay? I always like to do something that was kind of different from the crowd. And so I decided that I want to kind of see what it's like. And I was very fortunate that I was able to see it because I fell in love with it, and there was no looking back. And so to me, I wish I had a very inspirational story that one day I was walking and I saw pathology in action, and I decided no, it wasn't like that. It was really, kind of a long, drawn out process where I really wanted to make sure that what I'm thinking about pathology is the truth. So diagnostic, it's basically diagnostic medicine. You can go to the Inter-Society Committee on Pathology Information on the ICPI, and they have all of this data, and it's actually really cool. We teach medical students, residents, graduate students, and fellows. Pathology really is a place where clinical medicine and basic sciences can come together. So you can actually practice clinical medicine by diagnosing people, but you can also have research labs if you want to. Career options include going into community practice. So that's going into community hospitals that aren't academic centers, but you can also go to academic practice and teach in medical schools. There are some pathologists that go work in the industry. So for example, going and working with pharmaceutical companies, working on drugs, but they still have to look at what the pathologies are, and then naturally working for the FDA or for the government as well. When we look at how job hunting, so actually pathology is becoming a little bit more competitive than before, because I think people are more exposed to it now. But then also the number of residency positions that we have in pathology are not that many. They're probably around 3 or 4 on average openings per hospital, and there aren't that many programs. And so in general, it becomes kind of competitive to look at because the lifestyle is pretty good. And so here, basically just looking at residency and job hunting experiences. But right now I can tell you there's so many jobs in pathology at the moment. It always goes up and down, but there are hundreds and hundreds of jobs available for pathologists right now. This is very old data. Salary offered is definitely over 125. And in fact, it's probably over 200,000 now. 27% choose academic medicine, and around 60% choose community practice. I mentioned to you before that there are two types of residencies. One is an anatomic pathology residency, which is 3 years, and clinical pathology residency, which is also 3 years. But most people can combine them into an anatomic and clinical pathology residency, which is 4 years total. So instead of 6 years, you do it in 4. It basically makes you a specialist in every part of the laboratory, whether it be laboratory medicine or it be surgical pathology. And so I think that it's what I did, and it's in general what we recommend people do. But there are people who do AP only or CP only because that's what their career kind of demands of them. You can do subspecialty training in fellowship training. So for example, I've told you I'm a hematopathologist, so I've done hematopatology subspecialty training, but there's so many other things that you could do. In anatomic pathology, again, every subspecialty of pathology, whether it be pediatric pathology, bone and soft tissue pathology, lung pathology, you could actually become a specialist in that type of pathology. There are some mixed specialties. Heme path is one of them, I feel, because I kind of do a little bit of anatomic path and clinical path. But like I will start talking about in the beginning, forensic pathology, molecular diagnostics, and even informatics pathology is stuff that you can now do, which is kind of a combination. It's a good lifestyle, to be honest with you. I've been very fortunate to kind of find this. It's like, there's reasonable work-life balance. It's got more than above average professional satisfaction and family satisfaction. It has a reasonable professional respect. I think that, we because we're kind of behind the scenes, I don't think people look at us like they look at surgeons, for example, and I don't mind that. I don't necessarily care for that type of respect as long as they have respect for my diagnosis. And I would definitely tend to agree that there's below average stress. Starting salaries in the US are over $200,000. It's more if you go to obviously smaller cities and in community hospitals, and it's a little bit less, if it is in academic centers in big cities. But, there are lots and lots of board certified pathologists, and we always need more. There are lots of research opportunities. This is old data, but at that time, pathology departments had $400 million in NIH research grants. And, diagnostic medicine, if you think about it, if you think about molecular pathology and personalized medicine, which will be controlled by pathology in many ways, not controlled by, but involved with pathology in many ways, it's a growing market and people continue to fund it. So I am obviously practicing in a medical school, meaning that I'm affiliated with a medical school. So that's a smaller percentage of people. In general, the most common one is people being part of a pathology group, which is a private group. Once people finish residency, 20% or so do academic medicine. And the large majority of them, I would say it's not even 60%, it's probably like 80 to 90% do decide to do more training, meaning fellowship training. Because right now you can't just be APCP certified and then not do further specialty training. Actually, I would say that in leadership within pathology, my chair, if you think about the male to female ratio, it's actually very nicely representing women pathologists and women leaders. Many chairs of pathology departments are women, and they're exceptional physicians. My chair is a woman. Many of our vice chairs in the department are women. The directors of sections are all women, and so historically it has been a very nicely gender balanced and like kind of gender power balanced specialty. I would say that we can always do better. So there's no denying that we can always do better in that. But historically, it's actually been one. And the proof is in the fact that if you just Google pathology chairs, right, you'll see that many of them are women leaders. So as I mentioned, I'm an academic hematopathologist. I did residency in APCP and then fellowship in hematopatholgy and then fellowships in medical education. The hematology laboratory is basically a place where all blood comes to be tested. At Loyola Medicine, we do 1,000 CBCs, which are complete blood count. So that's like a little tube of blood that you kind of send to your lab. We do lots and lots of counts of different types of cells. The blood obviously has red cells, white cells, and then we look at bone marrow biopsies for leukemia. We also look at lymph node biopsies for lymphoma. So, right, and anyone has a lymphoma or a leukemia, then it comes to a pathologist like me. So here, what we'll do is we will switch gears a little bit, and I was asked to show you guys some. I was asked to show some cases of pathologies, and so I thought we'll talk about lymphoma. So I really don't know the people in the audience, whether how much you know about lymphoma or not. So this might be a little tricky. I don't want to burden you with too much information, but let's talk about lymph nodes. So in the body, there are many areas in the body where there are lymph nodes, and these are these rounded structures that are part of our immune system, right? And when you look at the immune system, so on the right is a cut section of a lymph node, and you can see these round structures in it. And this is just a normal lymph node. And what we know is that in the immune system, if you guys are familiar, if you've taken some basic immunology, there are B cells and T cells, and those are the main components of the immune system. And those reside, they flow around in the blood, right, as white blood cells. They can also stop in areas where they can basically be in lymph nodes, which are these little conglomerates of nodal tissue, which have B cells and T cells in them. One of the special ways that we can look at what those cells are by doing special stains. And so on the left, I'm showing you these brown, kind of some of the cells have become really brown, and that is because we put a special stain on them. And then based on that special stain, we can kind of identify whether they're B cells or T cells, or whether they have some special markers on them or not. Similarly, on the right, I'm showing you a separate study, and that's a flow cytometry study. You can also use special lasers, and you let the cells fall in a straight line, and the laser hits the cells. And depending on what reflects from the cells, you can type of figure out whether it's a B cell or a T cell or what have you. So we have to kind of figure out whether in a lymph node something is a B cell or a T cell, and then we have to figure out whether there's a B cell lymphoma or a T cell lymphoma. Here, what I will do is I will mention historically that there was a gentleman by the name of Thomas Hodgkin who lived in the late 1700s. And the reason I mention his name is because you will find that Hodgkin, maybe we can talk about it like at the end, but I'm pretty certain you should be familiar with Hodgkin lymphoma. Like you might have heard this word Hodgkin lymphoma, or sometimes people say non-Hodgkin lymphoma, right? And so basically, historically, the classification system of lymphomas started with Thomas Hodgkin. He identified a set of lymphomas that were known as Hodgkin, and I'll kind of show you what they look like under the microscope. And then anything that is not Hodgkin lymphoma is known as non-Hodgkin lymphoma. And I think these are kind of old terms now because we really need to be more scientific, but it is still the way a lot of people kind of identify as what type of lymphoma they have. So I'm a little bit of a history buff, and because I'm a hematopathologist, I love to talk about this. So Thomas Hodgkin was an apothecary in the day. He worked at Guy's Hospital in England, and he effectively was a man of many medical talents. He knew so much, and he kind of wanted really to push the field forward. And this is he went to Edinburgh Old Medical School. He worked there as an assistant. And there were many, many things. There's this book written about him called Perfecting the World, The Life and Legacy and Life and Times of Thomas Hodgkin. And in it, you find that, he was doing so many things. Like he's known mostly for the lymphoma, but, there was a stethoscope that has been thought to have belonged to him, for example. And he was on these mission trips, etc., where, he unfortunately passed away. One of his friends was Moses Montefiore, which I'm showing you on the left. And he had this gravesite built for Thomas Hodgkin. And I think that his life was it ended kind of too quickly. I think he died of some infectious disease. I don't know if it was malaria. I don't want to misspeak, but this is Latin for nothing human was alien to him, meaning that he kind of knew everything about human disease, which was pretty amazing. And this is his original drawings of lymphoma, right? So this is a dissection from post-mortem dissection. And, it's a drawing of all of these like large lymph nodes that are in this patient. And like naturally, these are lymph nodes. We know them as lymph nodes now, but at that time they were known as absorbent glands. And you can see why they were called absorbent glands, because it looks like they've absorbed something, right? So these were absorbed, so these were lymph nodes, and basically, the original, it's amazing how people were so fair. So Samuel Wilkes wrote this in 1865, but he credited it to Dr. Hodgkin. And so that's how naming happened historically, right? He could have easily called them Wilkes lymphomas because he was writing about them, but he didn't do that. He said, no, Dr. Thomas Hodgkin first described these, and so they should be known as Hodgkin lymphomas. And these are the original kind of colored drawings of Hodgkin's patients. This is a cut section of the spleen, and you can see that there are lots of nodules because of the fact that this patient is full of lymphoma. And in fact, if you go to England, the Gordon Museum in London actually still has the original specimens from Thomas Hodgkin's cases that you can actually go and view. I think it's not open to the public, but I think if you write to the museum curator or email them or let them know, they can arrange a time for you to come and see this. So it's actually very cool because you can see the original specimens. But because we now are very, very good at being able to understand what they were, the way we know Hodgkin lymphoma is because of the presence of this very classical cell. It's a cell which looks like it has two eyes and is known as a Reed-Sternberg cell, right? And if you see this type of cell in a lymphoma, you can say with pretty much certainty that this is a Hodgkin lymphoma. And any of the cases that don't have the cell are not called Hodgkin. But he didn't know this. He was only looking at them. He didn't have a microscope, right? So actually, when people looked at his cases, a lot of them ended up not being Hodgkin lymphoma, but that's a confusing story, so we're not going to go there. However, you need to look for this very characteristic cell, which has like the eyes-looking appearance, and this is known as a Reed-Sternberg cell. One of the people who described it was Dorothy Reed, and that's the Reed and Reed-Sternberg. And it's also a very interesting story. These are her original drawings from the 1800s, where she is looking at these interesting looking cells that are looking like eyes, right? And so there are different variations of these. But, you know, Dorothy M. Reed wrote, basically drew these out. Here, there's another interesting twist. Let me just make sure how I'm doing for time. Okay, I think I'm okay. There's another interesting twist in that Dorothy Reed was one of the first pathologist trainees at Johns Hopkins, and she kind of disappeared after describing this. And she had, and I always like to talk about the story because of the, injustices that have happened, especially to women physicians in the past, and how we can never have that happen again. So she had done more research than any of her male counterparts and asked the chair at Johns Hopkins whether she should, whether she can become a faculty member. And his response was that, no woman has ever held a position at Johns Hopkins, and there would be a lot of opposition to it. And so he didn't grant her the faculty position. So she was very upset naturally, and she had to accept this injustice. And so she left, and I think she went to Wisconsin, I believe, where she was from, and she became a pediatrician, and she had a very good career because obviously she was a remarkable woman. But, she, at that time, naturally, despite having worked harder and more than all of her male counterparts, did not get this position. And I feel like this injustice should be discussed as often as it can be so that things like this don't happen again. However, there's a romantic twist to this whole story. And that is that at Johns Hopkins, she was actually courting another one of the physicians, and his name was William McCullum. And we found out, this is in the early 1900s, I guess it's 1906, that he was basically writing letters to her. They were writing letters to each other. He was signing them off as a W. And when she had to leave Johns Hopkins, with her leaving Johns Hopkins, their affair ended. However, the historical thing, and the reason I'm mentioning it to you right now, is that William McCullum, here he is, wrote the first textbook of pathology. So here you can see McCullum. And he knew that Dorothy had done research about Hodgkin cells. And so in his 6-page copiously illustrated section on Hodgkin's disease, McCullum put Dorothy's name on every page except one. And basically at that time, it was going to become just Sternberg cells, but he named them Reed-Sternberg cells and kind of gave her a name in perpetuity associated with the research that she did. So while their love was unrequited, ultimately, her name was put in immortality with this cell because of all of the work that she had done. So Hodgkin's diseases were obviously described in the 1800s, and then there were bunches of names that were given to things that were not Hodgkin's disease, and ultimately they all got lumped into being called non-Hodgkin's lymphoma. And then we started looking at them and kind of seeing what types of cells they are, what they look like, and kind of giving them different names. But as our knowledge of the understanding of what these cells express, what their genetics are, has improved over the years, the classification systems of lymphomas have improved significantly. So this is like in the 80s, there were 6 classification systems. Then in 82, another classification system came into being. And what was happening was that pathologists were looking at these lymphomas and only diagnosing what they saw, but they weren't taking into account how aggressive the lymphomas were, what their therapies were like. And so at that time in World War II, there was an interesting thing that happened. It was obviously a war crime, I would say. However, it was interesting scientifically because there was a chemical warfare agent known as mustard gas. Okay, and it was in a ship. It was stored in a ship, and it was parked off the coast of Naples, and the mustard gas leaked. All right, so this chemical agent leaked, and the populations that were exposed to it, they started presenting with decreases in their lymphocytes. So the white blood cells started coming down. And while this was a tragedy, etc., scientists looked at this and said, oh, could this be developed into, if we controlled it, could it be developed into something that gets rid of lymphoma because it could decrease lymphocytes? And so that is how the first chemotherapeutic agent called mustine, which is derived from mustard, basically was found. And what we realized was that it isn't good enough to just give a diagnosis based on what something looks like. The diagnosis makes more sense, or the classification makes more sense if we also take into account what the survival data is. So there could be one lymphoma that does really well with treatment, and there could be one that does really poorly with treatment. And I know that you're so young, you may not understand survival curves, but what I'm trying to show you is that some survivals are better than others, right? And so ultimately, lymphomas were classified based on how they do. And they found out that they are either low grade, in which they do really well, high grade, in which they do really poorly, and then there's ones in the middle, right, which are intermediate grade. So now, although we always say Hodgkin lymphoma versus non-Hodgkin lymphoma, we should be familiar with which ones are low grade, which ones are high grade, and which ones are intermediate grade. And we also look at them. When we take a look at them, we can see, well, are they in like, do they look like this on the left, or do they look like nodules on the right? And so a pathologist basically does all of this work. My job day to day is to decide whether it's a Hodgkin lymphoma or a non-Hodgkin lymphoma. It's to describe what it looks like. It's to describe what the features are, whether the cells are big in size or they're small in size, or, what have you, are Reed-Sternberg cells present, what the genetics are like. I use laser, in my laboratory, there are lasers that look at, flow cytometry of these cells. And ultimately what I do is I use this classification by the WHO, which has many different, so all of these are basically non-Hodgkin lymphomas now. And so basically that's what I do to kind of diagnose lymphoma. We will now turn gears and talk about leukemia for a few minutes. And in leukemias, I think the coolest thing that I can talk to you about is this story of chronic myeloid leukemia. So I don't know if you know about CML, but chronic myeloid leukemia is a very specific disease. It is a leukemia which is in the blood. And it was described originally because these two scientists, Noel and Hungerford in Philadelphia in 1960, were seeing that in the chromosomes, there was a weird chromosome in these patients that had very high levels of white blood cells in their blood. And they didn't know what it was at the time. And so it was known as the Philadelphia chromosome. And this Philadelphia chromosome was actually looked at in detail by Janet Rowley, who was a physician at the University of Chicago. I have to name drop because I had the good fortune of meeting her when I was there. She has since passed, and she is a giant in the name of genetics in leukemias. And here she's receiving the Presidential Medal of Freedom on the right from President Obama. And she basically, that's a cool story. I could come back to talk about just her story. It's so fascinating. But she realized that there are 46 chromosomes in the human, but she realized that there's a chromosome called 22 and then one called 9, and a piece of 22 breaks off and joins chromosome 9. And then what's left of the 22 is actually the Philadelphia chromosome, this tiny little chromosome. And because of this translocation of one chromosome to the other, it's known as translocation 922, which causes the creation of a protein that doesn't stop. It just keeps working like crazy and ends up really, really proliferating over and over again. The cells just start proliferating. And when the cells are proliferating, it becomes a leukemia. It's a non-stop growth, right? And it's in the blood. So leukemia basically is it's effectively a disease where in the blood, you have lots of immature cells that are not control, like they're just growing like crazy, just keep growing and growing and growing, and they take over the normal bone marrow. And once they take over the normal bone marrow, they can obviously cause lots of diseases. And how you study them is usually you start by looking at a peripheral blood smear. So this is a slide with like some blood that's smeared out. I'm pretty certain many of you may have had blood smears of your own blood made. You may not have ever known. But the way you make a blood smear is by putting a little dot of blood on a slide, and then you take another slide and you move it across. And when you move it across, it smears all of the blood. And you can look at it, right? You look at the particular area in the blood smear and you can see beautiful cells. And the types of cells that you see are either red blood cells or RBCs. Red blood cells carry oxygen for you. So every time you breathe in, your lungs fill with oxygen, more oxygenated air, and then that oxygen transfers to your red blood cells, and the red blood cells takes them to different organs and where the oxygen is used. Then they come back to as deoxygenated red blood cells, and then they get oxygenated again. The white blood cells are basically multiple different types of cells, and they have lots of jobs. Their jobs primarily are to be part of the immune system, and so they ward off infection, etc. So that's what you think of as white blood cells. And then the third type of cell are the platelets, and the platelets help in clotting. So if you have a cut and you start bleeding, then naturally the bleeding stops if your platelets are working properly, and effectively that is a function of platelets. So it's basically these three types of cells that we're effectively always trying to look at when it comes to peripheral blood smears. So that's what I do. I look at these cells under the microscope. And when I look at these cells under the microscope, I try and see whether they're looking okay or not, whether whether their size is okay or not. And depending on whether it's size or whether it is something else, basically I can kind of guess what may be happening with the patient. The white blood cells can give you different types of morphologies. They have different types of granules. And I look at those to try and kind of explain to the other physicians that, oh, does this patient have an infection, or does this patient have a leukemia? These are lymphocytes. I look at lymphocytes in the blood as well. And I kind of can try and figure out whether they're B cells or T cells, or, whether the patient is having a viral infection or not. And these arrows are pointing to the little cute little platelets. They're small little structures, and they basically help in clotting. And so that's effectively what I look at. But they're all coming from the bone marrow, which is where hematopoiesis is occurring. And the bone marrow is an amazing organ. And that's also one of the things that we look at as hematopathologists. You take a piece of bone and the bone marrow from inside the bone, usually from the iliac crest, which is that little piece of bone that I'm showing you in the image. You kind of palpate the iliac crest, and then you have to take out crunch out a little piece of bone, and then you kind of look at it under a microscope. You also suck out a little bit of blood from there, and you kind of look at that as well. And there are different benefits of either looking at the blood, which is an aspirated blood from the bone marrow, versus looking at actually the biopsy. This is another way for me to kind of share with you, what things look like under the microscope. And so here I'm showing you two different bone marrows. You can see that this pink over here is the pieces of bone, but in between the bone is the bone marrow. And this bone marrow has all of the cells that are used to make our blood cells, right? So this is the factory. And in this factory, you actually have precursors to platelets, precursors to red blood cells, and precursors to white blood cells. And this is a cartoon showing you how that looks like. This is the bone. There are different parts of this thing. This is what the red blood cell precursors look like. They've got very beautiful kind of colors. They change in shape. Their nucleus changes in what it looks like as well. And ultimately a red blood cell is formed, and then that comes out into the blood. Similarly, as I told you before, white blood cells come from immature precursors. So this is an immature precursor, but over time, it kind of develops out and becomes the more mature looking neutrophils or eosinophils or basophils. And when we look at the bone marrow, we can kind of see how many cells are present in every stage, whether some of them are normally present in higher numbers versus some are present in lower numbers. And we actually look at it and count them. This is a very cool kind of image of megakaryocytes, mega meaning large, karyocyte meaning cell, and this is the precursor for platelets. And platelets are obviously the little things that help us clot. And I always like to put things into numbers. And so the platelets are actually just part of the cytoplasm of the cell. And I always like to ask if you can kind of even guess how many platelets humans make in a day. And we actually make to make it interesting, let's see, if we give a platelet, a penny for every platelet that we make, how many pennies would we have? So we actually make 100 billion platelets a day. All right, that's a lot of platelets that are being created all the time. So all of us right now, as we're sitting, our bone marrows are making platelets and they're coming into the blood, right? And so that means that it's like 100 platelets a day is like 5 billion platelets an hour. And at 1 penny per platelet, that's like a lot, like 50 million. Right? So that's kind of crazy. Think about it in like money form. And the way this happens is because megakaryocytes, which make platelets, have this amazing ability. All of you who've done biology, you've kind of figured out that you have mitosis, right? So a cell kind of doubles its nucleus and then it divides into two cells. But what the megakaryocyte does is that it doubles its nucleus, but it doesn't divide. It just keeps accruing more DNA, and then ultimately it can now create hundreds of millions of like platelets from its cytoplasm. So it's pretty amazing and a pretty unique cell. So I've talked about a lot of things about pathology, but I don't know if it really sums up who we are. I would say that we are behind the scenes detectives, and we are really providing timely and accurate answers that are needed for diagnosis and treatment of patients. And it's really a dynamic field of medicine. So don't think that it's not being a physician, and you use problem solving skills every day. And in fact, it merges medicine and biology and chemistry and technology and physics, right? There are machines there too, informatics and genetics. So you can kind of dabble in all sorts of things. And so the diagnoses that come from a pathology lab include basically every diagnosis, right? There are very few diagnoses that don't involve a pathology laboratory. For example, if you have a broken bone, you can get an X-ray and get the diagnosis, I understand, right? But other than that, whether it is a tumor, whether it is infection, whatever it is, you effectively are coming from a pathology laboratory. Like I mentioned before, the areas of focus, the list is really nonstop, and I'm happy to answer any questions about what other things could be on this list and kind of what it entails. Going through it, clinical chemistry is our chemistry laboratory. So any testing that needs to be done to look at anything that is in the blood. This could be markers of liver function, kidney function, thyroid function, any of those things. Drug monitoring in our patients, it's done in clinical chemistry. Urinalysis and looking at other body fluids is extremely important, right? So the color of the urine, are there any crystals in the urine? Is there any protein in the urine? Is there any, glucose in the urine? Like all of these things are important, and they basically form the reasoning for other physicians to try and understand what's happening. I won't talk about hematology or hematopathology because I've spoken so much about it already, but immunology. So like here, I'm showing you some, allergen testing on a skin, right? And the body is reacting to different types of allergens, but who studies what type of immunology it is? Like if it's what type of antibodies there are, right? I mean, even things such as COVID antibodies, people test for COVID antibodies, and which laboratory is doing it? Which laboratory is studying COVID? Who gives you the test for COVID-19? It's pathology, right? Like that PCR goes to a pathology laboratory, and we do hundreds of thousands of them right now. Like, literally like all the time we're doing testing for COVID-19, whether it be a spit test or a nasopharyngeal swab or like an antigen test, it is associated with pathology. HLA stands for human leukocyte antigens. The HLA laboratory is responsible for figuring out whether different organs will be compatible with different people. So for example, let's say if I need a kidney, my immune system is going to react to any kidney that comes in and will destroy it, because I will recognize that it's not my own kidney. So I have to get a kidney from someone who is immunologically compatible with me. And who does that testing? It's done in pathology. Again, like I mentioned, what about infectious disease? And so here there are bugs that are growing on agar plates. And so if you're interested in studying bugs or thinking about microbiology, pathology could be for you. Bacteriology, telling the infectious disease physicians what types of drugs the bugs are sensitive to versus what they're resistant to. All of that data comes from a microbiology lab. Getting blood transfusions, working up blood reactions, right? Do you know if you're blood group A, B, or O, or what have you? How did that data get to you? It came from a blood bank laboratory, right? And that's also in pathology. And then ultimately looking at the DNA, looking at your DNA, looking at your chromosomes, all of that can be studied in a molecular pathology laboratory, which kind of tells you everything that is happening on the genetic level. Nowadays, we also have to look at bioinformatics. So there's a ton of healthcare data that is being generated, and we need informatics specialists, such as health informatics specialists. And you can, as a pathologist, also start thinking about clinical informatics as one of the specialties that you look at. Cytogenetics is the study of chromosomes. And so effectively, it's not at the gene level, it's a bit higher level at the chromosome, right? So for example, the Philadelphia chromosome, which I showed you, will be a cytogenetic study. And cytogenetics is also something very important that has to go part and parcel with any of the diagnoses that we're making. So why, if you do go to medical school, why would you choose pathology? Or if you go to medical laboratory science graduate program? Because, it is, the pathologist is the physician that is making the diagnostic decision. It really allows for, if you are interested in being in medicine without seeing patients, I mean, that's not a bad thing. If you don't want to see patients, it's not a big deal, but you can become a pathologist. There's a tremendous amount of flexibility in this career, and it is extremely challenging, but amazingly challenging. And it is also very, very rewarding. I did want to quickly talk about the Loyola University Chicago campus. We are 13 miles west of the city limits. We are an academic medical center. We have tons of students, residents, trainees, fellows, and residents, and one of the nation's leading medical research and teaching institutions. The medical center that I work at is a level 1 trauma center. It has a children's hospital, a cancer center, and one of the most successful organ transplant centers in Illinois. It has a very large burn center and also a stem cell and bone marrow transplant program. So that was enough about pathology. Let me see about time. Right. So in the last few minutes that I have, I'm going to quickly talk about, we did this workshop for the College of American Pathologists. And so please Google it if you want to see the whole workshop. It's like 2 hours long, and you can actually learn more about Twitter. But I do want to talk about Twitter because Twitter to me has been a very cool tool. I think in many ways, it's how I, connected with the Pakistani American Pathologist Society, which I'm a part of, which kind of made my connection with TeleShadowing. So it is really your network, professional network. And it is a way, for example, like I have shared with you what the laboratory does. I can share on social media what this black box is and then get to a broader audience, right? So your personal brand, you can take to social media. I know social media can be kind of negative, or people like love Instagram because of the fact that they can follow influencers. I'm not really talking about that type of social media. I'm talking about social media where you follow people for their professional presence, for their professional opinion, and actually also for education. In many ways, you get continuous medical education in the 280 characters that Twitter allows. And for me, what I've been able to do is really establish a Twitter family. So there is a whole world known as Path Twitter for pathology Twitter. And we are numerous people there. We're a very friendly group, and we get together. This was obviously pre-COVID when we were doing karaoke in one of the meetings. But really my Twitter family is actually very, very special to me. But also I think that it gives you an idea to develop your social brand. I would say that, this is different from the Instagram account or the Twitter account that you may have for your hobbies, etc. It really is a way for people to recognize you, your candidacy, let's say for medical school, maybe for residency. It's another way to showcase what your talents are so that you can leverage your strengths. And right now, in the time of social distancing, many of you may be interviewing or doing things remotely. And this might be another way where, although you're socially distanced, you don't have to be social media distanced, right? Because that way you can still connect with people. So I think that it's definitely been one of the main things that has helped, my professional growth significantly. And I always try and talk about it at the end of any talk so that, people can kind of get inspired by it too. My strategies and goals are, my motivation to do it, which I've already told you. It's for networking and education. My goals are specific to me, are to advocate for the laboratory and for the pathology education. So I can do that on this platform. But most importantly, you have to be kind of real and professional in order to kind of circumvent the negative things that can happen with social media, because we all know that social media can be a rabbit hole and can be horrible. So we have to kind of avoid those things. Use tools, described in the Twitter workshop that you can kind of, these include hashtags and mentions and retweets. And this is a way that you can kind of build your engagement with other specialties, or even explore at your level. You can explore specialties, or think about what field you're choosing and follow some influences in that subspecialty. For example, let's say you decide that you want to become an orthopedic surgeon, kind of find the orthopedic surgery societies and kind of follow them. And watch out for different awards and scholarships, for medical school, for education, or whatever type of schooling that you're doing, and kind of apply for them and stuff as well. So that's my last slide. I think my time is up, and I'm more than happy to answer any questions.
Thank you for your mentorship and teaching, Dr. Mirza. I know I learned a lot. If anyone has any questions, they can feel free to ask now, and we'll now begin our Q&A session. So our first question is, personally, one myth we are told in schools is that pathologists and radiologists have limited interaction with patients, and if we prefer to work without them to become a pathologist. Many students in the chat were curious to know more about how much time you personally spend with patients versus, or if you spend more time analyzing and diagnosing patient tissue in the lab.
Yeah, so that's a very good question. I wish there was a different answer, but a majority of my time is looking at patient samples. So it is not talking to patients, it is making a diagnosis. And so I agree that that's not for everybody. Some people want to become a physician because they want to talk to patients. You have to go through medical school and really make sure that that's what you want to do, because when you're young, I also wanted to go to medical school to talk to patients, and I think I would have been a really great patient facing physician too. I'm pretty outgoing. I like talking to patients in clinics, etc. But I think that ultimately, yes, it's true that pathologists may not be spending so much time directly with patients, but I would venture to say that the job that they're doing, though, is extremely important, because if you get a wrong diagnosis for a patient, everything is messed up, everything. So if you are interested in kind of demystifying what diseases are like and making diagnosis, you should check out the pathology laboratory.
Thank you. And our next question is, what excites you about the future of pathology?
It's a great question. So I think what excites me is that as we're getting more and more familiar with artificial intelligence, we can use AI-based tools to make our diagnosis better and stronger. So for example, like right now we use special stains, and like I showed you that laser machine, etc. But as our technologies improve, we can potentially use newer and newer technologies in order to make our diagnosis more precise and more relevant to prognosis of patients. So I'm very, very excited about that.
Thank you. And how have HeLa cells contributed to advancing the field of pathology? And do you use any HeLa cell controls to diagnose specific metastatic cancers?
That's an excellent question. So HeLa cells are used primarily in research. They're not used in clinical medicine. So during my PhD, there was a time when I did interact with HeLa cells, but that was all research. It was not clinical diagnosis. So for clinical diagnosis, we do not use HeLa cells ever for control. And effectively, there's no use in the clinical environment. They're not part of diagnostic making.
Thank you. And given your worldview, having been raised in the UK with experience of the NHS, some physicians in the US are limited to the number of lab tests they can order for patients for insurance purposes. How can pathologists in the US work towards making healthcare more accessible to patients?
So, I think that both. So I was a child in England, so I'm not very familiar with like the details of like adult like NHS because I haven't worked for it. But I would say that in general, there's no perfect system. We all need to try better. I think that access to laboratory testing, that's a really elevated and an excellent question, and I'm very proud of whoever asked that question. I think that we have to understand that there are definitely injustices that happen because of healthcare issues, like insurance issues. And I think that in the United States, in general, physicians have many tests available to them that they may not have availability to in less developed countries. But I agree with you, our obstacle becomes insurance. And so at the end of the day, if there is a situation where a test is not being ordered, which would be very helpful, but because insurance won't cover it, that is an issue. What can we do? I think it starts with education. We need to educate our insurance companies and our elected officials and whoever is the decision maker in this process about the need for this testing and how important it is for diagnosis, because without diagnosis, there's no correct treatment. So I think it really requires a lot of research, and it requires people who know what they're talking about to be elected and in office, so that, if you don't have the scientific knowledge, then you won't be able to make a difference.
Thank you, Dr. Mirza. I'll now pass it off to Zaid to finish our Q&A.
Sure.
Thank you, Dr. Mirza. My name is Zaid, and I'm an undergrad student here in California. So for our next question, it's, what is your work-life balance like, and how are you teaching days split with your clinical days in the lab?
Oh, that's an amazing question. So I have a great work-life balance in the sense that, I am on service for clinical medicine, kind of half of the month, and then the rest of the half is basically split between my teaching. So I really can't give it percentages because I guess it would be like 60% clinical, 40% teaching and administrative. In reality, it's like every month can be different. Sometimes I can be teaching more. Sometimes I can be, doing more stuff. I have 3 children. My wife is also a physician, and work-life balance is great because there is an intrinsic flexibility in being a pathologist. When I'm on call, there can be some emergencies that I have to come and review specimens for, but that's not very common. In an academic center, I don't have to do that that often. Basically, I can split my day. For example, I can go in on a particular day, take a look at the important urgent cases, and then go teach for the rest of the morning, and then come back around lunchtime and then look at the rest of the cases, and then go back and teach or do some meetings. And so effectively, my day is a split. It's a hybrid of all the different roles that I do.
Thank you. Other question we had was, can you tell us more about flow cytometry and if that is something pathologists perform on their own?
That's a great question. Wow, that's somebody who's interested in flow. So flow cytometry is the machines are run by technologists or medical laboratory scientists, but the interpretation is done by the physician. So it's basically a way where we can take cells in a solution. So this could be in any type of solution. It could be blood, it could be fluid from like the lungs, any type of fluid basically. And that the cells are picked up into the machine and they're looked at one by one really quickly. A laser hits them and the laser light kind of goes everywhere. And then based on the pattern of light reflection, we have algorithms to study and see what types of cells they are. Are they big cells? Are they small cells? Are they B cells? Are they T cells? Are they malignant cells or not malignant? Like there's many things that the algorithm kind of teaches us. And then we as physicians interpret what that is. And so flow cytometry is interpreted by physicians. As a resident trainee, there are opportunities to sit with the medical laboratory scientists and perform the testing. But on a day-to-day basis, the technologists perform the test and we interpret them.
Thank you. Another question we received was, why is it important for physicians to be advocates in their social media presence?
It's a great question. So I think that there's a lot of misinformation right now, especially more than ever. And I think it's extremely important for physicians who are trained in those specialties, and are knowledgeable about facts surrounding medicine to be advocating for medicine, not only for patients to be aware of what's happening. This could be infectious disease physicians who speak about COVID-19. It could be immunologists who speak about the immune response of vaccines. It could be pathologists speaking about the importance of the laboratory, because ultimately it all comes down to government. How reimbursements happen. Hospitals need to run, and if you aren't an advocate for the type of job that you do, then you are always going to be at a loss for being. You could potentially be eliminated. Like your reimbursements could go down, the labs would shut down. So we have to be advocates for the profession, whatever profession you're doing. And one of the easiest ways to advocate is to do it over social media.
Thank you. And for our last question, what is some advice you have for students interested in pursuing a joint MD PhD program? And what are some research experiences they could pursue in pathology during their undergraduate careers?
That's a great question. So an MD PhD program is naturally a very unique program. I would say that you should be pretty committed to spending 8 years of your life to do it. There are benefits of it. There are also challenges, but numerous opportunities to do it. If a life of science and research and making your own lab is for you, then I think it's a no-brainer to try. It is a competitive program to get into, but I think the biggest thing that you can do is that definitely expose yourself to the research environment before you apply. Because first of all, if you don't have a significant component of research, you likely won't get into admission because people will not see why you're motivated to do the PhD component. So you have to do that. And as far as pathology is concerned, so any research that has tissues or organs in it could be considered pathology research. So you could be working on stem cells. That could be, like there's a way to kind of make it pathology. So I don't think that there's a specific pathology related research, like anything could be made pathology. So if you're looking at, let's say, lung cancer, there's a pathology component to it. If you're looking at blood cancers, there's a pathology component to it. And I collaborate with numerous people across the different research environments. And, I don't have a lab myself anymore because I focus primarily on clinical medicine and education. But I collaborate with people who kind of show me their data, and I look at the cells and I can kind of help cross collaborate. So there aren't any specific things I would recommend. What I would recommend for research, though, is go with what intrigues you. Maybe you would like to learn more about, I don't know, pancreatic cancer. Find a pancreatic cancer lab and work on it. And then definitely connect with a pathologist so that they can teach you about what the pancreas looks like, what pancreatic cancer looks like, so that you have an understanding of why you're doing the work that you're doing.
Thank you very much, Dr. Mirza. We truly appreciate you taking the time to answer all of our questions. This was a highly informative session for all of us, and I'd love to everyone please give a warm thank you to Dr. Mirza in the chat box for this incredibly informative session. Thank you.
My pleasure. Thank you very much for having me.
Now we're going to do our closing session and with our quiz and future session dates. So the link to the quiz for the session is now live. You'll need a 70% or higher to pass and receive certification, and the link is being sent in the chat now. Many of our students have expressed interest in pursuing a leadership position in teleshadowing. We have reopened our leadership application as we strongly believe in extending opportunities to others. And don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox, and you can join from the link that's being sent in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session next Saturday on December 18th at 10 a.m. Eastern Standard Time with our UK Medical Director mentoring us in OBGYN. Thank you so much everyone for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.